الرحيم. السلام عليكم ورحمة الله وبركاته. Today we will do a rapid review for important topic which is atrial fibrillation. You can face this patient in cardio station. Most patient will be rate controlled AF. There will be slow AF in case of cardio station. If you did not identify atrial fibrillation in cardio station, it's a fatal mistake. What are the causes of atrial fibrillation? Remember the mnemonic matches: mitral stenosis, alcohol, thyrotoxicosis, coronary artery disease, hypertension, and sleep apnea. What are the types of AF? We have paroxysmal AF, which terminate either spontaneously or by intervention within the first week of onset, mostly within 1 day. Persistent AF, AF that fail to terminate within first week. If it persists for 1 year or failed cardioversion, we are calling permanent AF. Lone AF, when there is no structural heart disease present. What is the treatment? What is the investigation you will do for AF? You will do ECG echo, you will do Holter, you will do electrolyte and renal function, you will do blood glucose and hemoglobin A1C, you have to do CBC also. If there is any focal neurological deficit, you should do MRI, and if you suspect sleep apnea, you'll do polysomnography. Treatment, you have to treat the underlying cause. Thyrotoxicosis, you have to treat. Alcohol, you should stop. Treat mitral stenosis. Rate control or rhythm control. Rate control, patient with BCD, either beta blocker or calcium channel blocker or digoxin. Rhythm control either by amiodarone or flecainide. Flecainide given to the patient with no structural heart disease. Amiodarone if there is association with heart failure. Cardioversion if the patient is hemodynamically unstable or less than 48 hours with low risk of stroke. Anticoagulation, NOAC or DOAC, apixaban, rivaroxaban, dabigatran, or warfarin, which is second line. If prosthetic valve, you should give warfarin. AF ablation, or if the patient has contraindication to start anticoagulation, or he will be poor adherent to anticoagulation, we can do surgical ablation. We are calling left atrial appendage percutaneous closure because the most AF arises from left atrial appendage. How to assess the risk of stroke? In AF, we know this score, CHA2, DS2, VASC score. Every score will give 1 point, except for the age more than 75, will take 2 points. And if past history of stroke or TIA, he will take 2 points. Okay? 2 or more start anticoagulation. If male, 1 is enough to start anticoagulation because female will take 1 by his age. Also, you have to assess the risk of bleeding. For patient receiving anticoagulation, we are using HAS-bleed score. H for everyone will take 1 point also. H for hypertension, A for abnormal liver or renal function, any history of stroke or bleeding, labile INR, elderly age more than 65, or patients taking drugs that promote bleeding and alcohol excess. Score more than 3 equal patient high risk score. So I wish this is a very rapid review for AF. You can help you for the exam. I wish if you like these videos, if you have any suggestion to any topic you want me to do a rapid review, I will do. Thank you very much and see you soon. Assalamu alaikum.